ACT is such an intensive set of services. It's so individual that each person is known every single day. If you're a consumer, you're talked about. You're reminded at the team meeting. You're remembered. If you happen to have called the night before in a crisis, the team knows it in the morning. They can just immediately reschedule so that you can get the attention you need.
They took chronic patients in a chronic mental hospital, discharged them all, discharged the psychiatrist, discharged the nurses, and the job was, okay, you treat these same patients that you've worked with for years, but do it in the hospital without wall.
The ACT is like, I've always heard, a hospital without walls.
Beneficiaries across the board said this is a better life. It is better for us to be out of the hospital getting this kind of care than have to live in the hospital. The state mandates that the majority of patients be treated in the community. And I think that's one reason, one way that they try and help with the back door. If a person doesn't need to have treatment out in the community, why can't they be treated in a more standard CMH type program? ACT takes outpatients, and the goal is to avoid hospitalizations primarily as the endpoint, and also indirectly to decrease the disability part of their illness. The psychiatric services need to be available. Obviously, none of us can be available 24/7, 365, but psychiatric services have to be available to the team, and that needs to be negotiated with the team.
We're all mandated to have our own ACT on call. We pretty much handle anything and everything that will pop up throughout the day.
One of the good things about an ACT team is that you can have people going out there delivering medications once a day, 3 times a week, more frequently, and that's something that we utilize frequently, and I think with a relatively high degree of success.
From a formal perspective, medical model treats disease. We get a disease and that's the focus. One of the problems for us in treating disease is that we don't have diagnoses. About the only diagnosis we have is Alzheimer's, because we stole that from neurologists. The others are all syndromes. Syndromes, cluster of symptoms. If you have these symptoms, we're going to put this label on it. We're treating disease, but we're not treating a diagnostic entity. I think that helps modify our thinking, and it certainly, as from my perspective, makes me a little more humble, because it means that I'm treating disease as it manifests itself, not illness. The hypotheses come from the patient. We hypothesize what's wrong by the patient. The patient tells us in 2 ways. The patient tells us by things we see. We observe. Symptoms are what the patient complains of. And we mix those 2 together. We mix things that we objectively see with things the patient reports. And that's what generates our hypothesis. And associated with that, we've got chronology. This happened, then this happened, then this happened, then this happened. It's hierarchical. There are people that report to people that report to people. So what's the clinical model? Or the rehab model? Key is, we're not so interested in treating disease. We're interested in restoring function. Clinicians generate the hypothesis. In the clinical model, we primarily pick up on this is what's going on. So it's looking environmentally, psychosocially at what is creating the illness, what is creating the syndrome. And again, you can see the complementary nature. There are multiple disciplines. The patient, the beneficiary, is looked at from different perspectives. From a nurse's perspective, this is what I see the problem to be. From a speech therapist, this is what I see the problem to be. And it is collaborative. The hierarchy part is modified so that there's a sense that everyone has relatively equal input.
Being willing to say, you know, I don't understand enough about what's going on here. What have you seen recently?
ACT is primarily built on the rehab model. We are primarily trained in the medical model. This is always going to create some tension in the relationship.
Some psychiatrists really like a hierarchy. They want to be in charge rather than being a collaborator. Some psychiatrists are very collaborative. That's hard, I think, sometimes, and it's hard working in a team when you're used to being the one. Ultimately the buck stops with you, and learning your team, learning to depend on your team, where their strengths are, where you can all work together more closely to make it better.
Probably close to 100 different doctors, and you have the majority of them that pretty much think, okay, I'm in charge, I'm the medical director, or I have the most education of everybody in this room.
Hopefully you have a self-selection process occurring where the people who are coming on to ACT already are predisposed to working together in a collaborative, interdisciplinary model.
I think that, for a doctor coming in, I think probably the most important thing they can do on their first day in terms of setting up for success is to be respectful and genuinely interested in the team, because you have to function as a team, as a real team member.
Unless they're out in the field seeing the people, they're really not in charge because they don't know them. And I think getting to know the clients and getting to know their team is probably the most important.
The ACT model it's a shared responsibility model, although within the team itself, some people have more responsibility. The team leader has particular responsibilities. The team nurse has other particular.
Like my boyfriend comes over and he spends quality time with me. They say, well, he's only supposed to be here so and so many days. I don't like that, because he comes there once a day.
Another thing is being able to be flexible with patients that have oftentimes very limited resources. Oftentimes no transportation, no phone, no limited access to a primary care doctor, all that kind of stuff you need to be aware of and be able to work around using your team.
Yeah, I had to piece all this stuff together because there's no money to try to have a sensible environment to be sitting in so that I'm not depressed while I'm in the house. Makes me totally sad.
Yeah.
Just stuck in a house.
Yeah, travel is always an issue up here, always.
Neat.
They gave me something on a support group at night in some church. I mean, that's not valuable. Because I leave the bus system at 6 and that's it.
Phone, there's no laundry facilities. They're having to rely heavily on Bee's brother to bring her and David into town. I think we need to have a discussion with Dave about if he's not able to get his diabetes managed properly, that he may have to go back to an AFC.
Because I got it in my head, you know, that I don't want to go out there quite yet, you know. And I don't know how to put that across to them that right now I'm not feeling well enough to go out and tackle the world.
Then here, I'm isolated, the mental illness took over, I wasn't working, a bunch of stuff happened.